I'm Peter Block here at ACC 17 in Washington, D.C., and with me is Deepak Bhatt from the Brigham and Women's in Boston. Deepak, we're at day one. This is the wrap-up, and it has been an exciting day primarily because of sort of the breakthrough issue over the past year, PCSK9 inhibition, 4-year trial in Orion. Give me your take on them because they are what everyone's talking about.
Well, first of all, it's great being here at ACC. It was a packed house in the late-breaking sessions. Hard to even get a seat in there. There were so many people. Good to see all that excitement. So there was a bunch of data about LDL lowering with PCSK9 inhibition in particular. So the Fourier trial, an outcome trial, several thousand patients showed a reduction in ischemic events with a PCSK9 inhibitor versus placebo. So validating that concept now, not just with LDL lowering, but actual clinical events. And sort of buttressing those results were also another agent with a much longer half-life. It can be injected every several months, which also seemed to lower LDL quite substantially. No outcome data yet per se. And then further complementing the data set, data from SPAR1 and SPAR2, a drug that probably isn't going to be further developed, bococizumab, because of neutralizing antibodies against that PCSK9 inhibitor, but still it lowered LDL for a period of time. And in one of the two trials, SPAR2, the higher risk patients actually a benefit in reducing clinical events. So for sure, for those skeptics out there, lower LDL is better.
Well, let me go back to the Orion trial because I think that's an interesting trial. Inclisiran, I think is the name of it. It's always a tough one to remember, but it's injectable. And an interesting part of that study is, or the concept behind it is, it takes the patient out of the issue of therapy, doesn't it?
Absolutely.
If you come in and get your vaccination once every 6 months, right, you don't have to think about it again. You don't have to take a pill every day. You don't have to do all those things that make compliance bad.
You know, we talk so much about adherence, what a challenge it is, in particular with statins, lots of side effects, most of them, not really based in science, but still from the patient's perspective, they consider them real. Here we've got an injectable therapy, as you said, every 6 months, you have guaranteed adherence.
Yeah. So much for PCSK9 inhibition. It's going to be around for a long time, and we'll see, I'm sure, lots of new ways of doing this. But this is exciting stuff. Maybe we won't have any work to do, Deepak, as interventional cardiologist.
Well, I don't think it's time for us to hang up our lid just yet, but one issue with the PCSK9 inhibitors, of course, is cost, not directly addressed by the data presented here, but for sure in town where we've been trying to get these approved, lots of barriers. The third-party payers haven't really wanted to cover it. Maybe now with some outcome data that might change. We'll have to see.
Okay, let's move on. Surtavi, the TAVR story goes forward.
Right.
The Edwards valve has been used since, I'm trying to remember, probably 9 months to a year for low-risk patients. Now the Medtronic valve.
Intermediate risk, yeah.
Intermediate risk, STS of 3 or higher. Well, that for me is low.
It is low.
That's right. Pretty low. In any case, now we have this trial, Surtavi, which shows us that the Medtronic valve, self-expanding, is in fact equivalent to surgery in these intermediate, most of these patients are 3 to 5 STS scores, so pretty low risk. And in Europe, of course, anyone who has aortic stenosis gets a TAVR. And the United States hasn't gotten there yet, but certainly what this will do, it will give approval almost certainly to the Medtronic valve, and I think for intermediate patients, and I think that will give us an opportunity to have better choices, which is always a good thing.
Absolutely, I think it's really good. Still need more data, longer term data in lower risk patients who are younger, just to make sure that there aren't issues with, subclinical leaflet thrombosis, whether that does or doesn't matter, any issues with structural valve deterioration. But certainly for the durations of follow-up in the patient study to date, these intermediate risk patients, TAVR seems like a winner.
Yeah, no question. So as we march down the STS score, we're down to 3, let's go down to 1 or 0. And let me ask you a question, Deepak. You're now 40 years old. You have a bicuspid valve, truly bicuspid, not terribly calcified, but some, and you are sick from that. Your valve annulus, and I'm going to trick you on this one, is only 23 millimeters. What do you want to have?
Well, so you've raised several competing sort of risks there. Personally, I think I would go for a TAVR, but if it were an actual patient in front of me, a little bit more of a complex decision. But now when you throw in the small root size, probably TAVR wins there.
Yeah, TAVR still wins for you. I'm not so sure I wouldn't go with the mechanical. Although, at age 40, we know the outcomes are terrific. But I have to take Coumadin.
Yeah, you're absolutely right. I mean, there's no free lunch, as they say. I guess I'd go with the TAVR with the realization that maybe I'll need another procedure down the road, but that's okay.
So those are issues that still need a little bit of clarification. And from ACC, the end of day one, thank you, Deepak, for being with me.
Thank you for having me.